Gottesman. I'm the Patient Services Director for the Scleroderma Foundation in Southern California, and I'm joined today by Dr. Daniel First, who is Director of the UCLA Scleroderma Program. Today we're going to answer a few questions that patients might be interested in learning about, and the first one today is, if I'm a patient and I'm worried that I may have pulmonary hypertension, what do I talk to my doctor about and what test should he order?
You know, it really is important to think about pulmonary hypertension if you have scleroderma. It turns out that most patients actually don't know when they have it. The symptoms of pulmonary hypertension are frequently things like feeling short of breath when you're doing things. But you know and I know that that happens for many different reasons. So I believe that patients who have scleroderma should always be screened on a regular basis for pulmonary hypertension.
And how should they be screened?
Well, first of all, you have to ask questions. Are you short of breath? A good one is, do you get short of breath after walking up a flight of stairs? That tends to be a hint. Then, on a regular basis, I believe people should get echocardiograms of the heart. And to really find out, you have to do some blood tests and often a right heart cath.
And what kind of blood tests would you recommend?
Some of them are simple. Find out whether you have anemia or not. Find out if you have an infection or not. Those can be done by straightforward things called complete blood counts. Look to see if you have an infection somewhere else, a urinary tract infection. Those can make you short of breath because you feel lousy. But there are also some tests which are more specific. One of them is called the NT-BNP.
And is that, can you elaborate a little bit more? What does that show you? And is that, if I get an echocardiogram, will I need this blood test as well?
Right. So the NT-BNP for now is really somewhat experimental for PAH. What it does is it reflects heart function. In PAH, which occurs in up to 30% of patients with systemic sclerosis when you put it all together, the heart strains to push that blood through the lungs. And so the heart reflects stress and even damage, and the BNP goes up. If the BNP goes up a great deal, then the research seems to indicate that it has a 95% positive predictive value, but it has to go very high.
If I am diagnosed with pulmonary hypertension, what treatments are available to me, and how do I know if the treatments are working?
So, first of all, we really need to be sure that the person has pulmonary hypertension. The echocardiogram, in which you just bounce sound waves off the heart, is a very simple test and non-invasive. But all it is a screening test. If the pressures in the heart, and particularly one side of the heart, are very high, that tells you a lot. But often they're kind of a little bit high. In that case, the only way to find out is to do a right heart cath. That sounds scary.
It sounds really scary.
Well, and sometimes it is, but most of the time, what happens is a small wire is placed through a blood vessel in the neck, run through the heart, into the lungs, and pressures are taken. For some people there's bleeding or there's significant pain, but 99% of the time it's pretty straightforward. It's not an inpatient procedure. You do it out, you just come in, get the test done, and go home.
And how accurate are the results?
Those, if you do a right heart cath, that's definitive. If the pressure is higher than 25 millimeters mercury in the arteries leading to the lung at rest, that is a definition of pulmonary hypertension. Why is that important? Well, it's important because we believe that very early treatment is actually life-prolonging.
If my echo is normal, is there any reason for me to get a right heart cath?
Very good question, actually. We believe that if the echo and exercise if the echo is normal at rest, but isn't normal on exercise, you probably need to move forward to the right heart cath. So we tend to do exercise echoes. Now, I think it's only fair to say that that too is sort of on the leading edge of research rather than fully established. But myself and my pulmonary colleagues believe very strongly that early treatment is very important.
Is this a heart disease or a lung disease?
Ooh, another good question. The answer is that, in fact, it's a lung disease. But when you think about it, if the blood vessels in the lung are smaller than normal, the heart has to work very hard to get that blood through. So as soon as you get pulmonary hypertension, you're going to end up having some heart problems as well.
So the type of doctor I would see would be a cardiologist or a pulmonologist or a rheumatologist.
Always a rheumatologist
Of
first.
course.
Of course.
At UCLA.
Of course. But, in fact, I think that the rheumatologist and, from my point of view, the pulmonologist have to work closely together. I think that if the heart becomes very, very significantly involved, you may need a cardiologist too. But most of the time, this can be handled by a rheumatologist and the pulmonologist.
And I understand there has been a lot of advances in this particular area of scleroderma. Can you elaborate a little bit more about maybe the most successful treatments and how to tell if those treatments are actually working?
Yeah. So, compared to 10 years ago, there are now 8 treatments that have been proven to be effective, whereas 10 years ago there were 1 or 2. There are multiple different mechanisms of action that might help patients with pulmonary hypertension, and now there are medications for each of them. We used to use one medication at a time, but now we tend to combine them, affecting the different mechanisms, and overall we believe pretty strongly that 1, people feel better, more energy, less shortness of breath, more able to do the things they need to do. 2, they live longer. So I think this is a life-saving therapy that has become available for scleroderma in the last 10 years.